it later. I welcome Dr. Prakash, Senior VR Surgeon from Comtrust Calicut. He has immense experience in managing endophthalmitis, and he will be giving a few pearls in the management of endophthalmitis. Over to you, Dr. Prakash.
So good morning all. Thank you, Mahesh. So these are the 3 pearls which you have to remember when you face a case of endophthalmitis, which all of us as surgeons, whether we like it or not, will have to face. The first most important thing is have an early suspicion and diagnose it clinically. We don't have any supportive means to diagnose a case of endophthalmitis. You have to do it clinically and never go into a denial mode. Always think that it can happen to you and diagnose it early. Second is, whenever you have an endophthalmitis, do your maximum to identify the causative organism. And also the third thing is early and aggressive treatment. Endophthalmitis, everything is not lost. Still you can retain or regain many useful vision for these patients. So the first point, first pearl, diagnosis is clinical judgment. Because you have to decide, as Dr. Thomas was telling, we cannot postpone it to an X-ray. You have to decide when the patient is right in front of you, you have to decide whether it is endophthalmitis or not. So those are the clues from symptoms, signs, as well as a history of the patient. So the most common symptom is blur vision, but the most specific symptom is pain. So if pain is present, it is always in favor of endophthalmitis. But remember, 25% of the patients may not have pain and 15% may not have hyperpain. So first postoperative day, you have a case with, it's very unlikely to be endophthalmitis, but if you see hypopain, then you have to think of it as endophthalmitis. After the first postoperative day, you have seen the patient on the first day, you have seen the amount of inflammation, then after that it worsens, patient still using drops, topical steroid drops, and it is worsening, then you have to think this could be endophthalmitis. And there are other clues, like you have to go through the history of the patient very carefully, pre-patient status. You look at the previous records, what was the status of the eyelids, was there any chalazion or anything which was done before, the surgery details, was it a prolonged surgery, was there a complication during surgery, all these things you have to go through, as well as clinical clues will be there, like if you see in the antechamber large white cells, and absence of keratic presence. Whenever KP is present, it could be a pre-existing uveitis that could be worsened. Presence of corneal infiltrates, vitreous exudates, as well as if you have fundus view and you see retinal exudates, hemorrhages or vasculitis, then it's almost always endophthalmitis. So with these clinical clues, you have to make a decision. And the biggest mistake I have seen is using B-scan, looking at the vitreous echoes and telling there is no endophthalmitis or there is worsening of endophthalmitis. Both are wrong, because vitreous echoes may be absent because for 2 reasons. One, it could be very early endophthalmitis where vitreous is only just getting involved. It may not be enough to cause vitreous echoes. First thing. Second thing is very fulminant organisms which like pseudomonas produce liquefactive necrosis of vitreous. Vitreous becomes liquefied. So you don't see much vitreous echoes. If you look at the top picture there, you see that there is significant thickening of RC complex. There is suprachoroidal fluid here, and there is that is almost like a panophthalmitis, yet you don't see much vitreous echoes. And see, after treatment the vitreous echoes has increased. So this does not mean that endophthalmitis is worsening. It happens when the endophthalmitis is responding also, because vitreous becomes more organized. The organized vitreous gives more echo. So that doesn't mean it is becoming bad. So this is one of the most important thing which you have to remember. But B-scan is essential, mainly because there could be a retinal detachment, which is a drastic complication of endophthalmitis, which you will have to diagnose. There could be masquerades like a retained lens matter, which also can be picked up only on B-scan. Second thing is, you have to go to any length to identify the organism, because for that particular patient it is important, so that you can give the optimal medical care for that patient. Also, you can make decision on early vitrectomy, because you identify a gram-negative organism, you would always go for an early vitrectomy. Also, you can prognosticate the disease. Medico-legal, it becomes, remember, it's not that you caused endophthalmitis, it's not the medico-legal issue. The medico-legal issue is you have not taken a standard of care in identifying and managing it. So that is the biggest problem. So to that extent, this will help you, and also prevent further outbreak. You know what is the organism, then you can prevent it if it is from your side, from your operation theatre. So the best and safest sampling method is taking an acid tap, which could be done by any anterior segment surgeon. And you always have a direct plating, because the yield, even in the best of the eye institutes, is less than 50% microbiological yield. So direct plating improves microbiological yield. So keep a culture plate in your OT. Even if you have a small hospital, you can contact the nearest lab, who will be happy to keep a plate there, which they will take if you are not using it. take back. And also keep a specimen back in your fridge for sending for a PCR if you don't get in routine microbiology. So it's very important to identify the organism. And third and most important is early aggressive treatment. So whenever you are diagnosed clinically there is an endophthalmitis, give an intravitreal antibiotic. That's a mainstay of treatment for endophthalmitis, because vitreous acts as a reservoir where your intravitreal antibiotic will lie, and it will, over the next 48 to 72 hours, it will release enough concentration of antibiotic to prevent further growth of the organism. And also keep the patient admitted in your hospital, monitor the patient every 4 hourly, and give systemic antibiotics with good ocular penetration. And the then last but not least step is decide whether this patient requires an early vitrectomy or not, and if it requires, send him early to a VR surgeon for surgery. So here your decision making is dependent on what is the onset of the endophthalmitis. It's a fulminant, that is less than 4 days is called as fulminant endophthalmitis. Then that means the organism is either very aggressive, or you have inoculated a large amount of organism along with the endotoxin, probably a contaminated fluid, into the eye. So these cases, not only treating the organism is not enough, you have to remove the endotoxins as much as possible, which is only possible by doing a vitrectomy. The other situation is the patient is not responding to initial intravitreal antibiotic. You assess for next 48 hours. If it is not responding, then you have to go for vitrectomy. And also if you have a complication like retinal detachment, you will have to refer for vitrectomy. So these are the 3 pearls: diagnose early, identify the cause, or make every attempt to identify the cause, and treat the patient aggressively. Thank you.
Thank you, Dr. Prakash. In summary, it is the value of time. You should not waste time, and systematic management as per the protocol. So, any question, madam? I invite Dr. Gopal Pillai for giving the next talk on intravitreal injections. Madam.
How do you explain the prognosis to the patient? Even if you have said that nothing can be done, they still expect something. So that is the major bear bug in managing endophthalmitis.
Never tell nothing can be done. We can do. We will the prognosis we cannot predict. We will tell the patient we will do the maximum that is possible, but we cannot predict the prognosis. The outcome may be good or it may be bad. We cannot. It's difficult to predict in endophthalmitis cases. So never give a promise. At the same time, do not discourage the patient. Everything is gone and you cannot do anything.
Giving bad news is an art. So you have to first make the patient understand that we are trying maximum for the benefit of the patient. That is the first impression. Then, unfortunately, we are not able to tell the final this thing initially itself. With our long experience also, it is difficult because it depends on the organism. So, give bad news slowly. It's an art actually.
Many times our problem as a VR surgeon is to protect the anterior segment surgeon. At the same time, we have to tell the prognosis also to the patient. So what I usually do is keep on asking the patient also. They will give some clue. Like somebody was telling the patient after the surgery, he went to a public toilet and you said that, did you do anything wrong? So he will think about it and I will tell I went to the public toilet, and oh, then that could be one of the, I will never tell that is the problem, but that could be. So that the honest, we try to put it lightly on the patient so that he won't get second thoughts like going to Ashok for medical legal hell.
A word of advice to all cataract surgeons here: never talk in your theatre. Your patients are under topical or local anesthesia, and the patient knows exactly when the lens went down into the vitreous. And if there is any problem associated with the case, they will associate it with your loose talk in the theatre.
Oh, I want to
never
add,
ever talk.
Madam, I want to add there that one of the instruments fell down once. And then the nurse and the doctor had a casual conversation. Oh, thaazhe poi, adu edukku. And then this patient, after 2 years, he met me somehow and he tells me that the IOL had fallen down during surgery. And then they had taken it and put it back in the eye. And that is why he has itching. Strange are the ways of